So let's get started. So it's my pleasure to have the Rasopathies network here hosting track number 3 for this introductory webinar about Rasopathies. It's a complex and disease area, because of course NF is also, and we know very well NF1 is part of Rasopathies, and we know very well the work that Beth and Lisa are putting into this. So thank you for taking the time and willing to work with the Hack4Rare. So we hope today will be a nice introductions, a lot of information for you to grab and to work on and answer some of those questions that we still have on all of these rare diseases. So I think I'll pass to Beth and Lisa for the introductions and take it away with the webinar. Thank you.
Excellent. Hi, my name's Beth Stronach. I am secretary of the board for Rasopathies Network, and I also am the parent, the mom of a son that has Noonan syndrome, which is one of the Rasopathies, and you'll hear a little bit more about that. And Lisa Scheuer is my co-presenter today from Rasopathiesnet.
I'm Lisa Scheuer. I'm a mom of a child that had Costello syndrome, and I'm the president of the Rasopathies Network.
I'm going to introduce the other folks when we go into our webinar slides. So I'm going to go ahead and share my screen. Today, you guys are here for the Hack4Rare. Oh, did that work? No. Maybe I'll just scroll through.
Yeah, it works. And maybe put it on, yeah, presentation mode. Perfect.
There we go. Okay. So as you know, we're here for the Hack4Rare, and we're going to talk about Rasopathies today. We're here from Rasopathies Network, which is a nonprofit organization that Lisa Scheuer founded in 2010. We're all volunteers, and we're running as parents of children with the genetic disorder of RAS signaling. Our mission is to advance research to improve the quality of life for Rasopathies families by bringing together families, clinicians, and scientists. And the Rasopathies are disorders caused by mutations in genes that result in excess RAS signaling activity during embryonic development and throughout the lifespan. And Dr. Rowan's going to tell you a lot more about that today. And I'll just point out our URL down at the bottom where you can find more information about our organization. Why is it not scrolling? There we go. So these are some of the children and adults that have Rasopathies. So I just wanted to show their lovely, beautiful faces. These were photos taken by Rick Gadati of positive exposure. And he always says this quote, which I love, but I'm not sure who to attribute it to. But it is, change how you see and see how you change. And so by looking at all these cute faces, you'll see the faces of the Rasopathies and hear more about them. I want to just thank Salvo and Children's Tumor Foundation for inviting us to partner on this cause. I think it's a really interesting opportunity. This is our first hackathon, and we hope to hear some really interesting pitches about solving the challenges that we have, and also the specific Rasopathies track sponsors, Costello Family Network, the International Costello Syndrome Support Group, and CFC International. Like some of the other tracks, we'll have 3 prizes, first, second, and third place. Won't go into that in any more detail. What we're here for is to hear about Rasopathies. So we'll have Dr. Catherine Rowan from UC Davis tell us about some of the scientific and clinical background of these syndromes. Then Tuesday Dyer will speak on behalf of CFC International about that syndrome and the challenges that they face as parents with CFC kids. Lisa Scheuer will talk about Costello syndrome, and then I'll finish up by mentioning a little bit about Noonan syndrome. So I'd like to welcome Kate Rowan, and you can share your slides at this point.
Good morning, everybody, or afternoon, wherever you may be. I'm just going to start sharing my screen now. Okay, and let me know if you guys can see it. Since I can't see, can you guys see it?
We can see it.
Okay, I'm going to put on
slide sorter.
Yeah, I'm going to put on slideshow. Okay. So I really want to thank the Children's Tumor Foundation for inviting us to participate in the hackathon. And as Beth said, my name is Kate Rowan, and I am a professor at the University of California at Davis, also a clinical geneticist. And I also want to give again a shout out to the Children's Tumor Foundation. I've actually been involved with them for almost 15 years now. They're a fabulous organization, and I am so glad, as we have all watched the RASopathies evolve over the last decade plus, that the Children's Tumor Foundation has actually been so supportive of the RASopathies that it's just been a real pleasure to help bridge that gap with the Children's Tumor Foundation and the Rasopathiesnet. So again, thank you so much. And so my job today is to introduce you to the RASopathies. But in order to talk about the RASopathies, we have to talk a little bit about the RASopathies and the RAS pathway. I know over this hackathon, you've heard a little bit about the RAS pathway, a little bit about RAS, a little bit about neurofibromatosis, a little bit about NF1, all of which are involved in the RAS pathway. But I'm going to show you how we're going to tie this all together with the RASopathies and NF1 and neurofibromatosis and the RAS pathway. So the RAS pathway is a really important, well-studied signal transduction pathway that is important in cancer, and it is highly controlled. And the job of the RAS pathway is essentially to get a signal from the outside of the cell, from the cell membrane, to tell the nucleus what it's supposed to do, because cells don't know what they're supposed to do unless they get signals through signal transduction pathways. And so RAS really is this important signaling hub that tells the cell what it's supposed to do. And as I mentioned, it's been really well studied in the context of cancer. So to dive a little deeper down into the RAS pathway and its components, as I mentioned, there are cell surface receptors that receive an environmental signal resulting in autophosphorylation. And this receptor, with its autophosphorylation, starts to recruit these really important signal transduction pathway proteins, one called growth factor receptor bound protein 2, GRAB2. And GRAB2 is an adapter protein which recruits another component of the RAS pathway called son of sevenless homolog, also known as SOS, as well as another protein called SHP2. And SHP2 is important because it's the protein product of PTPN11, which we'll be talking about later in regards to Noonan syndrome. So when all of this signaling starts to happen, RAS is also recruited to the membrane, and it interacts with SOS. SOS, which is guanine nucleotide exchange factor, it's known as a RAS-GAF. It helps to increase the speed at which bound GDP is replaced by GTP on RAS. And GTP, as you remember, is a really important energy component within our cell that our cell uses for energy. So RAS itself is a small GTP binding protein that really acts like an on-off switch, and it depends on whether it's bound to GTP, where it's in the on position, or if it's bound to GDP, which is in the off position. And RAS gaps are also really important as part of the RAS pathway. And RAS gaps are RAS GTPase activating proteins that turn RAS off by aiding in the conversion of GTP to GDP. So it decreases the energy of the pathway and decreases the signaling of the pathway. So the RAS pathway has a lot of downstream effectors. And as I said, RAS really acts as a signaling hub to signal to all these different pathways. And this is just a handful of pathways. It's so much more complicated to this, but it signals to the pathway mediated by RAF, which is important in cell cycle progression and transcription, differentiation, survival, and motility. So very important pathway. RAS also signals to RAL-GDS, which you can see here is important in transcription, membrane trafficking, vessel formation, and so on. The PI3 kinase pathway, also really important studied in oncology, PLC epsilon, TIM1, and so on and so forth. But today we're really going to focus on the RAS mitogen activated protein kinase pathway. And the reason why it's called mitogen activated protein kinase pathway is it's because mitogens are things that signal to the receptor that make the pathway turn on. That's why it's called mitogen activated protein kinase pathway. And this is what we are going to be focusing on today. So diving a little deeper down into the RAS-MAPK pathway, so we understand all the genes that are involved in RASopathies. RAS itself is a family of GTPases, which include KRAS, HRAS, and NRAS. And those are the major players in the RAS pathway. But there are many, many, many more RASes. These are the ones we're essentially going to be focusing on today. And then once RAS is activated, it recruits RAF from the cytosol to the membrane. It's important to know that all three RASes can recruit RAF, and RAF also exists as a family of proteins. And the family includes BRAF, CRAF, and ARAF. And all of these RAF isoforms can go on and phosphorylate and activate MEK1 and MEK2. And then MEK1 and MEK2 can go on and phosphorylate and activate ERK1 and ERK2. So you can see that this is really like a bucket brigade in the sense that it's taking a signal from the cell membrane, it's going through this RAS-MAPK pathway, and then it phosphorylates and activates ERK, which is really the workhorse of this pathway, this activation of ERK, because ERK itself has numerous cytosolic and nuclear substrates that actually tell the cell what it's supposed to do. So if you turn this pathway on, which again has been studied very well in cancer, and now so in the RASopathies, you have to turn this pathway off. If you don't turn this pathway off appropriately for one reason or another, then you have a possible cancer or you have a possible RASopathy. And so there are lots and lots and lots of different proteins within the cell that help turn this pathway off, that help modulate this pathway. And there are these RAS gaps. There's sprouty proteins, there's sprouty related proteins, there's lots of kinase inhibitors and lots of phosphatases, including also SPRED1, which we'll talk a little bit more about as well. So the important thing is this pathway is very important in the cell and telling the cell what it's supposed to do. But in doing so, we have to modulate and turn the pathway off. So all these components. So here's the RAS pathway, the RAS-MAPK pathway. And the RASopathies actually include a group of medical genetic syndromes that have different pathogenic mechanisms in the fact that there's different pathogenic variants or different mutations within different components of this pathway that essentially activate ERK. So there's different mutations within this pathway. And when you look, and I'll mention this later also in this talk, but when you look at all these different components, and when you look at the RASopathies as a whole, we're really talking about the most common multiple congenital anomaly group of syndromes that we know of today. So who are the RASopathies? The RASopathies include neurofibromatosis type 1, which has been talked about in this hackathon. The RASopathies also include Noonan syndrome, which we're going to be talking about today. Noonan syndrome with multiple lentigines, capillary malformation, AV malformation syndrome, Costello syndrome, cardiofaciocutaneous syndrome, Legius syndrome, SYNGAP1 autism, and a new group of syndromes that cause lymphatic disease or anomalous lymphatic disease. So you've heard a lot already in the hackathon about neurofibromatosis type 1. So I'm just going to go over NF1 briefly today. But what I am going to be doing in today's hackathon talk is we're going to compare and contrast NF1 to the other RASopathies, because NF1 really was the first described RASopathy. As you've already heard, it's an autosomal disorder where about 50% of the individuals have a brand new mutation, and about 50% of the individuals with NF1 have a genetic pathogenic variant that they've inherited. It is relatively common for a medical genetic syndrome. It's about 1 in 3,500, I actually rounded off to about 1 in 3,000. And there have been criteria that have been developed used for routine clinical diagnosis. That is diagnosis that can happen at the clinics, your clinician's office based on physical exam. And so briefly, again, you've heard about this over this Hack4Rare hackathon. And the phenotypic diagnosis includes cafe au lait macules. It includes intertriginous freckling, most commonly axillary or inguinal freckling. The freckling can also take place in the groin area or on the neck. 2 or more neurofibromas that can be found on the skin or underneath the skin, or a plexiform neurofibroma. A brain tumor, most commonly an optic pathway glioma, is also part of the diagnosis. New to the diagnosis are special choroid abnormalities, so 2 or more contribute to the diagnosis, or 2 or more Lish nodules, which are kind of freckles on the iris or iris hematomas. A distinctive osseous lesion also contributes to the clinical diagnosis of NF1, and shown here is a tibial pseudoarthrosis. And also new to the diagnosis, new criteria that have been developed for this diagnosis are a pathogenic mutation in neurofibromin, or the gene NF1, that are found in 50% of the tissue that has been examined. But neurofibromatosis is more than just signs on the skin and signs in the eyes. We always have to remember that neurofibromatosis can include cardiovascular abnormalities, and cardiovascular abnormalities can include things like pulmonic stenosis, aortic coarctation, coronal truncal defects, mitral valve issues. EKG abnormalities can happen in individuals with NF1, as well as hypertrophic cardiomyopathy. Also, it's important that we monitor and watch for hypertension and vasculopathies, osteopenia, frank osteoporosis, vitamin D deficiency is found very commonly in NF1, scoliosis, vertebral dysplasia. So this is why individuals with NF1 and other RASopathies, it's really important that they're followed in specialty clinics by either neurologists or clinical geneticists that really know about neurofibromatosis type 1 and other RASopathies. And what's really interesting and really demonstrates how this is a pathway event and a pathway issue is that about 10% of individuals with NF1 have Noonan syndrome craniofacial phenotypes. So sometimes it's very difficult from a clinical standpoint. When I see NF1 patients in clinic, actually they look a lot like Noonan syndrome individuals, and this is because of the pathogenetic mechanism of the RAS pathway. And the pathway, it works, it's important, and this is why we're talking about the RASopathies today. So this is NF1, the first RASopathy. And so now I'm going to introduce you. Let me mention this is an oncogenic pathway. And so there are cancers that are associated with NF1. And even though there aren't any screening criteria for NF1, except for early screening for breast cancer in individuals, women with NF1, we also have to remember this is a cancer pathway. Malignant peripheral nerve sheath tumors can be seen, astrocytomas, pheochromocytomas, JMML, otherwise known as juvenile myelomonocytic leukemia, medulloblastomas, rhabdomyosarcomas, and melanoma, again, along with breast cancer, are found in individuals with NF1. So, Noonan syndrome, also a RASopathy, a close cousin of neurofibromatosis type 1. But as you can see, a big difference already is, yes, it's involved in the RAS pathway, but look at all the different genes that can contribute to a phenotype of Noonan syndrome. There's 19 genes and counting, which is very, very different from neurofibromin as the sole genetic cause of NF1. So Noonan syndrome, like NF1, is autosomal dominant, and it can be new in the patient itself, or it can be by familial transmission. So that is the same as NF1. Like NF1, Noonan syndrome is also common in the population. It's out there in the literature that it's about 1 in 1,000 to 1 to 2,500. This is actually in the literature. And I can tell you right now, this is a big underestimation in the population. It's probably more like about 1 in 600, 1 in 500. Anecdotal. I'm just putting that out there. So its genetic cause, as I mentioned, is heterogeneous, multiple genes, and there are still other genes that are out there that need to be identified. And I feel that we are going to be identifying these genes because exome sequencing and whole genome sequencing are so much more common. So Noonan syndrome has very distinctive craniofacial features. Again, as I mentioned in NF1, about 10% of individuals who have a clinical and a molecular diagnosis of NF1 have craniofacial features that are almost indistinguishable from Noonan syndrome. Cardiovascular anomalies can be seen in about 80% of individuals with Noonan syndrome. This is a much higher frequency than NF1. It's about 80%, as I mentioned, and pulmonary valve, hypertrophic cardiomyopathy, septal defects can be seen. Growth and development are affected in the majority of individuals. And in your PTPN11 individuals, which comprise about 50% of the population of molecular pathogenic variants in individuals that are diagnosed with Noonan syndrome, their height typically does fall on the lower end of the development curve. Gross motor delays may happen. Learning disabilities can be seen in individuals with Noonan syndrome. It's in the literature about 25%. This might be a little bit higher, especially when we talk about executive functioning and so forth, which again is a big issue also in NF1. Hematologic issues, lymphatic issues, I think, which are really understudied in Noonan syndrome, especially lymphatic issues, can affect up to about a third or around a third of individuals. Skin findings are unique to Noonan syndrome. Keratosis pilaris, which is the goose flesh, the bumpy goose flesh, which can be seen in teenagers on the extensor surfaces of their arms and legs. So it's very common in the population, but it's much more common in Noonan syndrome. Café au lait macules, they can have lentigines. So what I'm saying is the skin findings in Noonan syndrome aren't nearly as pathognomonic as what can be seen in NF1. So this is a big difference between Noonan syndrome and NF1. Noonan syndrome is a cancer syndrome. There are cancers that are associated with Noonan syndrome. There really aren't any screening criteria. JMML, like NF1, can be seen. ALL can be seen. Rhabdomyosarcomas, neuroblastoma, juvenile pilocytic astrocytoma can be seen. And essentially, when you look at these particular cancers, they are cancers that can be seen also in NF1. So moving on to Noonan syndrome with multiple lentigines, it is a close cousin of Noonan syndrome. It's actually caused by two of the same genes that can cause Noonan syndrome. So it's relatively rare. It used to be called leopard, and I'm mentioning this just because you'll see this in the literature, which stands for lentigines, EKG conduction defects, ocular hypertelorism, or essentially hypertelorism. That's wide space between the eyes. Pulmonic stenosis, abnormal genitalia, retardation of growth, and deafness. This is an antiquated term. It's called now Noonan syndrome with multiple lentigines. I mention it just for literature's sake. And it's caused by very special, very unique genetic variants that are in the gene PTPN11 and RAF1, or also known as CRAF. Yes, in vivo, when you look, the RAS-MAPK pathway is activated, but when you look at these particular mutations, they're actually catalytically defective in vitro, and they go on to activate other pathways within the RAS pathway. So they're very, very different. The reason why the lentigines is because as children develop, actually more so in their upper torso area, they can start developing these freckles. They can get cafe au lait macules, just like NF1 and Noonan syndrome. But the skin findings can be very unique to Noonan syndrome with multiple lentigines. Doing a literature search, it's unclear if there is a cancer connection with Noonan syndrome with multiple lentigines, though as you dive into the literature, you'll see that there are individuals that have been diagnosed kind of one-off, and that you can see here. So I want to just jump and briefly mention capillary malformation, AV malformation, also a RASopathy. And this is a really interesting RASopathy. You don't really get those craniofacial features. Actually, this is more of cardiovascular, vascular development, where you can get these AV malformations or arterial malformations, meaning where the artery and the vein actually don't develop appropriately, where you don't have that capillary bed in between the artery and the vein. And so you get this malformation, which can actually be high flow. And they're atypical. They can be cutaneous in nature or found on the skin. They can be in the bone. They can be in the muscle. They can be in the heart. They can be in the central nervous system. And so these AV malformations can occur anywhere. There has been one paper, which is now a little dated, that actually did look at other issues associated with AV malformation. And other issues have been identified, including tetralogy of Fallot, septal defects, valve abnormalities. But again, this is really something of capillary malformation and AV malformation. But it's really important to be recognized as part of the RASopathies, because this actually points us to AV malformations which can occur and other cardiovascular anomalies that can occur in other RASopathies. Costello syndrome, also one of the RASopathies, due to activating mutation in a single gene. So that's very different from NF1, very different from Noonan syndrome, very different from Noonan syndrome with multiple lentigines. There's only one gene which causes Costello syndrome, and that is HRAS. HRAS is more rare. It's one of the rare RASopathies. As I mentioned, it's caused by activating mutations in the gene HRAS. The majority of individuals, 80% plus, have a G12S missense mutation, followed by G12A missense mutation. But there are other more rare mutations in HRAS that can happen. And like Noonan syndrome with multiple lentigines, there are very distinctive craniofacial dysmorphic features. And the features are similar to Noonan syndrome, especially in the newborn period. But when you really have seen thousands of these individuals, thousands of these kids, the craniofacial features can be seen as more coarse. Like Noonan syndrome, about 80% of individuals can have cardiovascular anomalies, hypertrophic cardiomyopathies, valve defects, septal defects, arrhythmia, hypertension. So very similar to what is seen in Noonan syndrome and very similar in frequency to Noonan syndrome. Like Noonan syndrome, growth and development can be affected. In fact, the majority are affected in growth and development. The majority, if not all, have failure to thrive. GI issues are very common: short stature, growth hormone deficiency, motor issues, hypotonia, speech delay, all can happen with Costello syndrome. Cutaneous findings are very interesting, very unique to Costello syndrome. In fact, the cutaneous findings in Costello syndrome, many of which can be almost pathognomonic towards the diagnosis of Costello syndrome, much like the skin findings in NF1 can be pathognomonic for the diagnosis, the clinical diagnosis for NF1. But individuals with Costello syndrome can have generalized hyperpigmentation, which really shows the neurocrest ridge development issue in these RASopathies. Soft redundant tissue can be seen, which points to a collagen issue. And collagen, as we know, is controlled by the RAS pathway. So that makes sense. Scalp and hair abnormalities, papillomas, which are unique to Costello syndrome, mostly unique. There have been papillomas been identified, but at a much, much more rare frequency. Hyperkeratosis can also be seen in Costello syndrome. We also have to remember hypoglycemia can happen at birth. I've also mentioned about skeletal muscle issues. They can have bone issues, joint issues, pectus deformities, as well as myopathies, which we have identified and defined in our lab. Ocular issues are very common: strabismus, nystagmus, astigmatism, myopia. They can also be hyperopic. Generalized osteopenia, like NF1, like Noonan syndrome. Vitamin D deficiency can also be seen. Like the other RASopathies we've talked about, cancers can be associated with Costello syndrome: embryonal rhabdomyosarcoma, neuroblastoma, transitional cell carcinoma. These cancers in these syndromes and these RASopathies, we really don't know why some people get cancer, why some people don't get cancer. This is really a great need for study, looking at background genetics, looking at any genotype-phenotype correlation. So this is a great need moving forward in the RASopathies. Cardiofacial cutaneous syndrome, also a RASopathy caused by pathogenic variants in KRAS, BRAF, MEK1, and MEK2. What is interesting about CFC syndrome is you are really looking at the RAS MAPK pathway, RAS, KRAS, and the MAPK pathway, including BRAF, MEK1, MEK2. So that is truly a pathway effect. Just like Noonan syndrome and just like Costello syndrome, craniofacial features are seen, and they can overlap one another, again, contributing to the pathogenic mechanism of the RAS pathway. Very difficult to distinguish a newborn with a RASopathy, but as children get older, the features become more distinctive. Just like Costello syndrome, just like Noonan syndrome, 80% of individuals have cardiovascular issues, valve defects, hypertrophic cardiomyopathy, septal defects, arrhythmias can happen. So again, What's really interesting is not all patients with CFC, even though it's cardiofasciocutaneous syndrome, have cardiovascular issues, just like Noonan syndrome. Again, background genetics plays a great part in this. And so again, a great need to figure out why some patients have some of the phenotype and others do not. Growth and development, just like the other RASopathies, are affected. The majority have short stature. They can have speech delay. The majority gross motor delay. Some degree of neurocognitive defect. Again, there's a very wide spectrum in neurocognition in individuals with RASopathies, from normal IQ, normal neurocognition, to some that are greatly affected. We don't know why. What is the background genetics? What does the genetic alteration have, and how does it impact their particular signaling? Cutaneous findings, the vast majority, if not all, can have scalp and hair abnormalities, hyperkeratosis, keratosis pilaris, or erythema ophiogenes, progressive mole formation, and hemangiomas. Neurologic complications can be seen in individuals with CFC syndrome, macrocephaly, ventricular defects, speech delay, learning issues, cortical tract findings. But this is the big difference that I want to point out for the RASopathies. CFC syndrome and neurologic complications include seizures. And this was an old study that we did actually a long time ago. We had about 40 patients, about 38% did present with seizures. This is probably an underestimation, as we now have more patients in the cohort of families with CFC. And the issue with the seizures with CFC syndrome is they're very stubborn, in the sense that polytherapy is required. They can have mixed seizures, tonic-clonic, absence, infantile spasm, complex partial seizures. So again, this is something that really is a need of area of study in CFC syndrome. Ocular issues are commonly seen: optic nerve atrophy, ptosis, strabismus, nystagmus. Again, the majority of individuals have ocular. Is cancer associated with CFC syndrome? The answer is probably yes. ALL, non-Hodgkin's lymphoma, large B lymphoma, neuroblastoma. But the thing is there's no screening protocol. There's no screening protocol in any of the RASopathies. And again, I think this is a great need to dive a little deeper, doing some genotype-phenotype correlation in cancer and the RASopathies. I just want to mention Legius syndrome due to SPRED1 haploinsufficiency. It's autosomal dominant. It can be transmitted in families. It used to be called NF1-like syndrome, so it's a close cousin of NF1. The gene SPRED1 actually interacts at the molecular level with neurofibromin, which makes a lot of sense because, again, this is almost a phenocopy of NF1, but unlike NF1, they do not have those lumps and bumps that we see in patients with NF1. There's no Lisch nodules, no neurofibromas, no CNS tumors, at least that have been reported to date. They can have lipomas. So this is a lipoma. They can have lipomas, which is not something that's commonly seen in NF1. So that's an interesting switch up. I just want to mention SYNGAP1 autism. SYNGAP1 is a SYNGAP. It's a RAS gap. It turns the RAS pathway off. It downregulates the RAS pathway. SYNGAP1 is expressed only in neuronal tissue, and when you look at the neurocognitive issues, the issues in SYNGAP1 individuals, they're very similar to other issues that have been seen in other RASopathies, including global delay, hypotonia, intellectual disability, neurocognitive issues, behavioral issues, sleep disturbances, hyperexcitability, anxiety, autism spectrum disorder. Again, these can be found in all of the RASopathies. And so you can see, based on a pathogenetic mechanism, that the RASopathies really are a large group of syndromes. They have common and overlapping phenotype. And why the RASopathies are so important including NF1, the first RASopathy, is you really see an intersection between cancer and development. You know, the RAS pathway is an important pathway that has been found in oncogenesis and development. And the RASopathies have a common pathogenetic mechanism of ERK activation. I mentioned ERK in the beginning of this talk. ERK is really that workhorse, which tells the cell what it's supposed to do. And here we have activation of ERK where there's not supposed to be activation of ERK. The RASopathies have these germline mutations, which is very similar than cancer. Remember, cancer is something that you develop and you have these genetic alterations in somatic cells, cells that aren't the germline. These patients are born with these genetic alterations that have been functioning during development and causing their phenotype. And these genetic mutations can be actually the same that has been found in cancer, and they can be novel as well. So these novel mutations actually are important to help us understand how these genetic components impact, how these genetic changes impact the gene, and how these changed genes alter the protein conformation and how they alter the pathway. So understanding how genes from RASopathies work in development really will give us clues as to how it functions in cancer and vice versa. That's why understanding these RASopathies is really important from an oncologic standpoint to understand what these genes are doing, which is going to really help us understand what's going on in cancer. But the bottom line really is understanding the RAS pathway, understanding these genes will really help us towards better treatment for our patients. And that's what it's all about. So thank you, everybody. I'm going to stop sharing my screen.
Okay, thank you, Dr. Rowan, so much for that extensive review of the RASopathies. I think it was really interesting to see the overlaps and the unique features. And that's really a big question as to why the syndromes can vary within a family and also between families that have different or similar mutations. So now I would like to turn it over to Tuesday Dyer. She's going to tell us a little bit about what it's like to be a parent of a child with CFC. And she is the executive director for CFC International. So take it away, Tuesday. I will share my slides again so that we can look at.
Perfect.
Move forward. Oh, there we go.
Thank you so much for having me today. As Beth said, I am the executive director of CFC International, and I'm also a mom of a child with CFC syndrome, and he on your screen is in the top right corner with my reading glasses on. Those are not his glasses, but he is 7 years old, 7 years old in that picture as well. So that's a pretty recent picture. But I want to paint a picture for you just a little bit after we've really had this great opportunity to review the scientific findings and understandings of CFC syndrome through Kate's presentation. I want to talk about a little about the daily life of individuals with CFC syndrome. You'll see in these pictures on your screen, you are going to be working with some mentors from CFC International, and each of these wonderful smiling faces represents a mentor family that you'll be working with. So we have an added incentive to really just work with you to make sure that we have as long as we can with these amazing kids. With a great quality of life. That's really what we're ultimately looking for. And so when we think about quality of life, we know that there are some challenges, and certainly you see the smiles here, but I know for each of these smiles on the back end, the challenges can relate to developmental delays, neurobehavioral issues, simple things like figuring out how to have accessibility in the classroom, a wide range of issues. And so when we talk to our parents and we survey them and we really try to figure out, what is really impacting their daily life, we hear pretty heavily some basic things. How do I make it so that my child can learn and be in a classroom where they can absorb information and they can have a quality experience, a quality of life experience. And so how do I manage non-neurotypical behaviors? How do I manage things like ADHD, autism spectrum disorders, self-injurious behaviors, and how do I really manage the psychological issues that we see that are prevalent within CFC syndrome? The other piece we see is, how do I work with my child on communication needs? How, if my child is nonverbal and they're 15 years old, how do I know they're in pain? How do I manage pain? And verbal and communication issues are a very wide spectrum in CFC. So my son is 7 and he has a pretty interesting vocabulary. But for some families, their child can be 15, 16, even in their 20s and have very, very limited verbal skills. And so being able to talk about what's happening in their bodies or any pain they're experiencing can be a problem. I'll share with you anecdotally, one of the experiences we had, and I'll talk about our seizure study in just a moment, is that when my son was talking with researchers, he was able to tell them exactly what it's like to experience a seizure. He was able to say, I feel a little funny, then the left side of my body shakes uncontrollably, and I don't know what to do about it. But not all of our kids can express that, and many of our kids have significant delays. And as Kate said, the range of delays are pretty widely spread. Everything from pretty severe intellectual delay and disability to very, very moderate to almost no intellectual delay and disability. And we're seeing that more and more as we see new individuals being diagnosed, because now we're starting to see people who are perhaps in their 40s and never knew they had CFC syndrome. And now they're having a child with CFC syndrome and they're learning that they in fact have CFC syndrome as well. So the landscape of the disorder is changing quite a bit. The other piece that we see, and this goes into that group of really surveying our parents and having an understanding of what their challenges are, is sleep. And so for many of our families, they can experience almost no sleep with their child to very intermittent sleep. And so sleep disorders continue to be a pretty prevalent obstacle. And as you all know, and I probably don't need to say this, but I will, is that as sleep can impact those non-neurotypical behaviors, they can impact the psychological findings, they can impact their ability to learn in the classroom. And so for some of our families, they feel like if we can just really get a handle on the sleep disorders exist in CFC syndrome, we can actually create a much better quality of life. And so we'll go to the next slide.
Sorry.
So what we wish we knew. So boy, this is a very, very long list. But two things are happening within CFC International right now. One is that 2 years ago, we embarked on funding a study of seizures in CFC syndrome to really get a good grasp of how prevalent they are. Unfortunately, for the purposes of this hackathon, that data will not be available yet, but by the end of the year, we will have some publications that indicate, and I can say this now, that indicate that seizures are much more prevalent than we thought. And in fact, the majority of individuals with CFC syndrome do have seizures. The other piece is we wish we knew how to really better diagnose and identify with individuals with CFC syndrome. And so we know that there are a lot of as I said, of families who are coming forward now who are saying, you know, my child is 25 and now all of a sudden we know that my child has CFC syndrome. And so those initial phenotypical things were not expressed in the child. And so it made diagnosis very, very difficult. Additionally, we find some discrepancies, and we just received a grant to study this piece as well, in health equity and how that equity is displayed in the diagnosis process. And so how we create better outcomes for all families who potentially have a loved one with CFC syndrome and overcome some of those health equity barriers, specifically when I talk about health equity barriers, I'm talking about race or socioeconomic status.
Hey, Tuesday, how many families do you interact with CFC International?
Yeah, so we have with CFC International 796 diagnosed families. We are excited because we have very engaged families. And so even with our seizure study for the past 2 years, we have 159 participants in that study. So we're getting good quality information. I want to share too, we actually have a registry within Invitae. I'm going to put in Slack how you can access that registry. I had a meeting with Invitae this morning, and there's 2 ways to access that registry. One would be a more complex way, which is actually signing up for an Invitae account and being able to access the de-identified data on our patients. We have 356 individuals in our registry. And so you can create an account. Invitae is ready to accept and approve those accounts coming through the hackathon. And you'll be able to download that information about our families or individuals with CFC syndrome. The other way is if it's a little too complex, you can always reach out to me through Slack and say, I really am having trouble getting this de-identified data. Can you just send it to me? And so I can also provide whatever information you need from Invitae, working with Invitae and their coordinators there to give you that data as well and put that data in Synapse if that's what we prefer. But that's where the majority of our patient data lies, is in Invitae. Of course, we have numerous studies that have been done on CFC syndrome, everything from recognizing heart abnormalities to growth abnormalities. And as Kate said, obviously our individuals with CFC syndrome are shorter on stature, and that seems to be a significant quality of life issue for our families as well, because there are no growth charts right as we speak right now. There are no growth charts specifically to CFC syndrome, although I know there is there's work being done in that area. But overall, the data, if you are trying to access the data, or if you have any other questions about CFC syndrome specifically, I am happy to interact with you at any time on Slack, as well as our other 5 mentors.
Thank you so much. It's really great to hear directly from a parent and about what the families are really experiencing in day-to-day life, and how we can include the patient voice in anything that comes out of the hackathon, as well as our scientific research, because that's really the important piece. What are you experiencing and living with on a day-to-day basis? So I appreciate your perspective. And now I'm going to turn it over to Lisa Scheuer, and she can tell us her experience with Costello syndrome.
Hi, everyone. I'll try to make this, try to keep us close to the time frame. Yeah, so a lot of the things, as you heard from Kate and then from Tuesday, are similar things in Costello syndrome. And so here's a picture of 5 different children from different continents, and you can see how they're similar. Next picture, next slide. So this is Quinn, and I think, so he was one of the children who developed cancer, as well as Helena down at the bottom here. Helena developed cancer twice, and the second time the chemotherapy really messed up her spine so that her heart was at risk. Her hypertrophic cardiomyopathy was at risk with her spine and rib cage twisting in the process of the side effects of the chemo. So, Tuesday said kind of the same issues. The sleep is really hard for families. And, we talk among each other, could it be night terrors, but what are the therapies? What can we do about it? And the medical field is sort of like, it's not our area. So it's really challenging. And I suspect actually trauma from all the medical issues that they have. Eating is a big issue. Usually 99% of them need G-tubes, and it takes very little to have them throw up again. You know, all their balances are very tenuous, so it doesn't take much. So like a cold can cause them to have to throw up, to throw up for 3 weeks, just a simple cold, just because of all that mucus that can just imbalance everything. Usually the eating resolves by somewhere between the ages of 2 and 12. It is the most stressful time for families because the kid's not sleeping, the kid's not eating. And for several kinds of cultures, it's even more complex if their culture or their family doesn't believe in, being supportive. There's some cultures in Southern America where they say, what sin did you do to deserve to develop to have such a child? So helping with the isolation is really, really important. And that's how our family organizations really work. Unfortunately, we're only reaching people who speak English and have computers and have computer skills. So I think coming to this new level of app, I think that could be really helpful at another level to reach them. Adding more the sweat. This is something, again, that I think it's a temperature regulation issue, but in the early days, especially, our children sweat so much that we have to change the bed linens in the middle of the night. It's that kind of sweat. So don't know what's going on there. And then the ligament and muscle issues that you can kind of see. You can see Quinn sitting in the sink. He's 17 months and he's not able to sit alone there. But you can also see him coming up, 5 years old. He's got a little sister. We're all laughing at her crying. And then Quinn, when he developed cancer, rhabdomyosarcoma. So, and Helena here, as you can see, sort of a similar situation. She's got her legs in splints in the second picture, enjoying the Bush Noel. And the amazing thing about her is, despite all the challenges that Costello syndrome has done, she competes at the Blackpool Dance Festivals and gets awards. So they're hardy as heck, despite all the traumas. Okay, next slide. So because Costello is so rare, we really keep on learning from each other. And we need to, and because of the complexity, we kind of rely on each other. It's really hard though. So, Quinn had cardiac, vision, orthopedic, GI, speech issues, to name some. He had 21 specialists, 9 case managers, and there's so many body systems involved and so complicated. It's like you get doctors and therapists saying, why aren't you doing what I recommended? It's because like everything's piled on and we can't keep track. There is a Costello syndrome consensus document that was recently published that helps families get their doctors to consider all the various syndromes, systems that should be checked. It'd be great to somehow get that into the hands of people who don't have access to it, families, doctors. So that's the managing piece. In terms of collecting, we're still collecting information from families. And this is a challenge because we're all working family members, or we have a child that's very involved with their child's care. So it's really helping us collect information to help advocate for care would be really great. The things that kind of float up are pain and anxiety, and then all the special education goal developing issues. The whole special education piece is a whole nother layer that doesn't get addressed. So I keep on talking about how for Costello syndrome, because we're so small and we're so, really on the edge of being overwhelmed, strategies to help us, even to call out, we really are a pool of live data. And I know it gets challenging with respect to, well, HIPAA's not an issue, but human research, getting IRBs. We do have access to be able to get that pretty quickly if that is the situation. And our families, the ones I polled, it's like, yes, if we can do some way to do surveys and collect information so we can show it to the doctors, that would be really great. So thank you. On to Beth.
Okay. Thank you so much, Lisa, for sharing your story. I'm going to just be really quick because we already talked about Noonan syndrome, but here's my son when he was young toddler, and now he's 15 years old. I think you can see some of the facial features. He's got the curly hair. He has the sort of triangular shaped face. He did have a heart murmur at birth, and he was slow on the growth chart, which was one of the things that our pediatrician had identified. So he has pretty typical manifestations of Noonan syndrome. You've seen the pathway now, and so one of the unique things about the Noonan syndrome and group of Noonan-like syndromes is that it seems to encompass so many different genes. And so that's both a challenge and kind of a treasure trove as well. But PTPN11, which is one of the phosphatases, mutations in PTP1011 account for about 50% of the total cases of Noonan syndrome. This slide just attempts to show that there are both unique and overlapping features of all of these syndromes. And I'll just mention once more, echoing Dr. Rowan, that even though some of these syndromes are quite rare, some of them are fairly common. If you think 1 in 1,000 people have Noonan syndrome and they may not know, and they're walking around, and put together, this is really a huge group of individuals across the globe that can attribute things that affect their quality of life to signaling in the RAS pathway. And we hope to leverage all of the work and the resources that are put into the oncology field, including some of the oncology therapies, the oncology drugs, to potentially use for treatments for the RASopathies. And I'm sure you've heard that there's been one FDA approved drug now to treat one of the manifestations in NF1. So we're hopeful that we may be able to expand some of the clinical trials for our individuals as well. So to get to the pain points, these were things that we came up with that might be amenable to problem pitching. As you heard, some of the neurocognitive and behavioral issues are really some of the greatest challenges for parents. Despite some of the physical limitations and the verbal limitations, the sleep and the behavioral things can just be so challenging on a day-to-day basis when you don't really know why your child is upset, or your child's in pain, but they can't communicate and tell you why or what's hurting. So we hope to understand, sort of even at the systems level, at all levels. So at the population level, what are the neurocognitive features? What are the behavioral issues? There's been several papers that are published in this area. It's an active area of research. And then all the way down to what's happening in the brain, what structures, what neurons, what parts of the brain are affected, down to what are the neurotransmitters that are potentially gone awry that underlie some of these behavioral aspects. So I think that's a really rich, deep area that we need more information about to potentially come up with ideas for how to address and potentially treat some of these features. We have part of that then is overcoming the barriers for finding people who can work with and understand RASopathies families' needs, as well as for the parents and children to be able to or caregivers to be able to communicate their needs. So I think there's some areas there that could be addressed. And as I mentioned, sort of the molecular genetics of nervous system development and nervous system dysfunction that underlie the neurobehavioral challenges would be really useful moving forward, either for targeting therapies or for developing endpoints for trials, all that kind of stuff. And then lastly, but certainly not least and not comprehensively, we've heard that you know, vitamin D is one of these things that is out of balance. There seems to be different pain thresholds. A lot of the families discuss that their kids respond differently to different drugs. So there may be differences in the way they metabolize drugs. They certainly, many of them, as you could see in the pictures, have lean phenotypes. So they tend to be thin, small. They have feeding defects, but also within their cells, they may have different metabolic issues. So I'm not sure if there are metabolomic resources out there yet, but I think it would be really interesting to try to find markers that would be imbalanced or dysfunctional within the different syndromes and see if that could be used as a biomarker. So I think that's also sort of a rich area that could be explored more. I know we're short on time, so I just wanted to mention that and we can open it up to a few Q&A here at the end, but next week already upcoming will be another overview webinar on the actual pitching, hacking 101, how to pitch a problem. That will be happening on Monday. On Friday, the actual hackathon will kick off, and we're really excited about that. We can't wait to hear all the great ideas. And lastly, a pitch for our symposium that is coming up at the end of July, and you can go to our website to find out more information about that. And also just to keep referring back to the Hack4Rare website in order to find new content, more people to interact with over Slack, and that the webinar will be available as well. So thank you to our sponsors, both our Rasopathies specific sponsors and all the community partners that have partnered with CTF. So we really appreciate all of their input, and just excited to be part of this experience. So I'll stop sharing, and if we have some time for discussion, we can answer a few questions.
Yes, but I think you covered most of the questions also on the chat. They were answered either on the chat or live. I don't know if there is any other questions that are coming through. There's just one question from Debbie. I was curious about the education issue associated. Are there visually interactive education system for these children?
I can speak to that because we experienced that personally. So yes, there are some barriers there, especially if communication is compromised, if verbal communication is compromised. The majority of our children in an educational setting use either an iPad or a Slackboard or something to the like that the school provides for them to be able to communicate their needs and to learn effectively.
And Quinn learned sign language. This is since he died in 2002, missed all that stuff, but he learned sign language to be able to communicate. It was coming slowly, but part of it too is the coordination of the tongue in a mouth that is, the tongue is slightly large and the mouth is slightly small. A soft palate is also involved. So, you know, all sorts of little things that don't quite fit.
Yeah, that's a really, really interesting point. I think sign language is probably underused in these cases. So
yes. And for Emmett, he has cerebral palsy, which is also somewhat prevalent in CFC syndrome. And writing is just something that really his educational experts really just kind of stepped in and said, let's not make him learn to write. Let's just use all of these great communication tools we have that we know are going to be more and more prevalent as years pass.
Okay, I think we are ready to wrap up. Just as a reminder to the speakers, and thank you guys for taking the time to explain all of this information. I want to just mention that problem pitching is open to anyone, even the organizers, or you Tuesday or Kate or anyone who has an interesting problem that wants to focus the attention of the group on. If you have a problem, post it. Even if you're not able to let's say, work actively, but it's just the problem. We don't want a solution. We just want to know what the problems are. And I'm sure there will be people that will pick that up, or, you know, will resonate at some point and work on it. So problem pitching is critical for successful success of this hackathon. So I'll invite all of you to be there and, you know, post your problem.
Awesome.
Wonderful.
You can post many. You can post not just one. You can post multiples. But
There will be many.
don't
Yes.
overdo.
Okay.
Focus on what is most important.
Well, thanks,
Okay.
Salvo, for organizing, and thanks everybody for coming. Appreciate it.
Thank you.
Thank you, guys.
Thank
Talk to
you.
you soon. See you next week.
You bet.
Bye-bye.
Bye.
Bye-bye.
See you tomorrow.